Good afternoon, ladies and gentlemen. We bring you greetings from Richmond Media, Richmond Media Health Issues. We warmly welcome our viewers and our listeners from the globe. And special way, we welcome everyone to today's health issues. Beloved, as we always wish, it's the wish of God that we always have perfect health and good health as well. Therefore, Richmond Media Health Issues is our concern and it's our focus that each and every one around the world will also have better health. Today with me is a different day and we have a special guest. Today's topic, we are going to tackle about pregnancy-induced hypertension. Everyone who has the intention of getting married is also thinking of giving birth. And as part of the pregnancy period, there are some things that if we are not careful, we are about to encounter. And that is what we call pregnancy-induced hypertension. So today, we are going to dive deeper into this topic and know how husbands, we can help our wives. Wives, we can be able to maintain our hearts and how it is beating so that the pregnancy will not induce it. Today with me, we have a special guest and we will introduce her to you. So we will welcome Miss Favor Agojo to join us. And Sister Favor, please, you are welcome to Richmond Media Health Issues.
Okay, thank you very much for the opportunity. I'm very grateful to Richmond Media for this opportunity to also share a little knowledge about pregnancy-induced hypertension. And I hope that by the time we are done with this presentation or this discussion, mothers will be empowered. The main word here is empowerment, because sometimes, because of lack of the knowledge, people who get pregnant and have or develop hypertension in pregnancy may end up having very bad outcomes because of the lack of knowledge. So I'm very grateful for the opportunity, and I hope we have a very fruitful discussion.
Thank you. So to our viewers, you have heard from someone who said the horse own mouth, and we have known how best we will be enjoying today's lesson. So we want to go into our lesson. We have put the flyer on board, pregnancy-induced hypertension, pregnancy-induced hypertension. Please, can you take us through the hypertensive disorders in pregnancy? Thank you.
Okay, so thank you very much once again. So like you earlier on said, you talked about the fact that it's every woman's joy, right? That once they get married, those who actually want to conceive or embark on pregnancy do so. And we expect that that process is normally physiological. All the challenges or the changes that will be going on throughout that pregnancy is supposed to be physiological. And we expect that the woman should carry the pregnancy to term, that is around 38 to 42 weeks of pregnancy, and deliver successfully without any complication. But research has shown that pregnancy-induced hypertension, right, is one of the causes or the leading causes of maternal mortality. And due to this, it's very important that we raise the awareness on what? High blood pressure in pregnancy. And like you rightly said, they are actually a group of disorders, right? So when you talk about pregnancy-induced hypertension, in pregnancy, all the hypertension that occurs are actually not pregnancy-induced. So normally we group them under a group of what? Disorders or conditions that is characterized by high blood pressure, and this normally occurs during pregnancy. So we are expecting that in pregnancy, your blood pressure is supposed to remain in the normal ranges throughout the pregnancy, through delivery, and even after delivery up to 42 days, right? Which is known as the period, right? Yes, but there are some pregnant women who experience high blood pressure during pregnancy. So all those high blood pressures we identify during pregnancy are grouped as what? Hypertensive disorders. And these disorders, they can potentially lead to serious complications, right? For birth, for both the mother and also what? The baby, right? So hypertensive disorders, in as much as it may look a little distant from us, is actually a very common complication. That's what medical complication that normally occurs during pregnancy, right? And it can be so bad to the extent that it can become very severe, and we may lose the mother and the baby, which we are actually not expecting. No, it's okay. Please, sorry for that interaction. So that's about it. So we know that for high blood pressure, the readings, when they are about 140/90 or more, then it means that high blood pressure is actually what? Abnormal. Then a lot of investigations has to go into it to know how best we can manage that mother so that she and her baby could actually be safe and sound and deliver and end the pregnancy with good pregnancy outcomes. I think that would be about it for the pregnancy disorders.
Thank you for the insight, because everyone thinks that it's normal when you are pregnant, you eat like the time you were single and you were not double. So they are just abusing things, and if not knowing that if you are not careful, we are likely to have this condition. Now, look, Sister Christiana Sapon said, God bless you, sister, for this topic. So just the
Thank you.
introduction, this is what our viewer is saying. So to our cherished viewers and our listeners, the ongoing discussion is that pregnancy-induced hypertension, and we are just looking at some hypertensive disorders that occurred in pregnancy, and that is what we are still discussing. We want to ask again, do we even have types of these hypertensive disorders like the normal hypertension that we can classify them into groups? And if there is any, can you take us through the types of pregnancy-induced hypertension? Thank you.
Okay, thank you very much. So, like I earlier on said, it's not every when you take a pregnant woman who may develop hypertension in pregnancy, it's not all of them that are classified as the pregnancy inducing the hypertension, right? So there are various types of hypertension that occurs in pregnancy, right? And one of them is gestational hypertension, which is the common one. And this kind of hypertension is normally brought about by the pregnancy. So with this kind of hypertension, the woman may not have been hypertensive, right? But during the process of pregnancy, she develops that hypertension. And normally, to be able to diagnose or classify that type of hypertension as gestational hypertension, then it means that high blood pressure should be occurring after 20 weeks of pregnancy, which in our traditional ways, we normally say 5 months of
Okay.
pregnancy. So after 20 weeks, if you identify that your blood pressure is going up, especially above the 140/90, then that is classified as gestational hypertension. And with gestational hypertension, there is no presence of protein in the urine. So every pregnant woman knows that when they go to the antenatal clinic, urine test is normally done, right, to determine whether there is protein in the urine or glucose in the urine. This is the significance of that test that is being done. It's actually to determine whether you are having protein in the urine or not. So if you have high blood pressure but there is no protein in that urine that is tested, then we will classify that as gestational hypertension. And normally, with this kind of hypertension, it usually returns to normal after delivery. So once that pregnancy is over, the woman delivers and the placenta is delivered, then it goes back to normal. So that is what we term as the gestational hypertension. It used to be termed as pregnancy-induced hypertension, but day in, day out, the terms keep changing. So it's the same as the
Sure.
gestational hypertension. Okay.
Okay.
Then we
You
also
can
have,
continue.
okay. Then we
Yes,
also
please.
have chronic hypertension, right? So with chronic hypertension, unlike the gestational hypertension, which occurs after 20 weeks, with chronic hypertension, immediately pregnancy is confirmed and the woman comes to the antenatal clinic for antenatal services, and you check the blood pressure and you notice that it's above 140/90, you classify that person as having chronic hypertension. It means that this pregnant woman had the hypertension before actually getting pregnant. So that is classified as what? Chronic hypertension, right? Then we have another type, which is the preeclampsia. So with the preeclampsia, it also occurs after 20 weeks of pregnancy, but with preeclampsia, there is the presence of urine protein. So with all the types that I'm stating here, you identify that they keep increasing with their severity.
Sure.
So with preeclampsia, that mother will start having protein in the urine, because you are not expecting protein to be in the urine, right? But because
Yeah.
of the condition, because of the high blood pressure, it may be having an effect on the kidneys, right? And that will
Okay.
make protein be present in the urine of that pregnant woman. So once you see protein in the urine, then you classify that type of hypertension as preeclampsia. Preeclampsia. Then we also have the chronic hypertension with superimposed preeclampsia, right? So with just like the name is implying, chronic hypertension simply means that the woman had a pre-existing chronic hypertension and later on develops preeclampsia. So with that one, they are having the chronic hypertension, then also having protein in the urine, right? And this
Yeah.
can actually be a little devastating for the mother, because they are already having the chronic hypertension and now having the superimposed preeclampsia. You can have organ damage, and the organs that are normally damaged are the kidneys, the liver, and it can even go to the extent of affecting the brain, right?
Okay. Yeah.
Okay.
Then it means our viewers and listeners, if even you've not up to this time heard anything, the moment you get pregnant, there is a need to visit the antenatal clinic
Sure.
so that
Sure.
these things that we are mentioning, you realize that if we are detecting it earlier, it means when we read the intervention side, there can be immediate intervention. But if we delay, as the advice is going, and we refuse what Mr. Favor is telling us, then it means that we are going to reach a state where an organ can damage. And that is
Yes.
where reach more media health issues. We don't want our lovely wives, our lovely women who are about to be pregnant, rich. Thank you for this insight. You were mentioning about preeclampsia. then I know after this you are going to take us deeper into the preeclampsia and its types. So, viewers and listeners, you realize you alone cannot listen to this. Therefore, invite your friend to also listen to this so that at least we can be able to maintain a healthy environment and a good pregnancy, safe delivery outcome. Thank you. So please, can you take us through the preeclampsia and its criteria? Thank you.
Okay, so thank you for that. So, like you rightly said, we normally don't want our mothers to get to the severe form of hypertensive disorders in pregnancy, because there's management. There's actually management. There are a lot of women who have developed pregnancy during hypertension during pregnancy, or even who had hypertension, got pregnant, but they have been able to give birth successfully. It's all about early detection, right?
Sure.
Being able to detect it early and being able to what? Manage it, right? So we
Yeah.
have certain criteria that we use when we want to classify preeclampsia, right? So with preeclampsia, once you are diagnosed as that, it's not actually, excuse me to say, maybe a death warrant, because we
Okay.
have different categorization of the preeclampsia too. We have those that are mild, we have those that are moderate, and then we have the severe form of it, right? So the
Okay.
criteria for diagnosing preeclampsia is women with gestational age 20 weeks and having a diastolic blood pressure greater than 90, and also having protein in their urine, right? So that's the criteria we use to diagnose preeclampsia. So when you go to the antenatal clinic and your blood pressure is checked, right, and the blood pressure is above 140/90, then a follow-up test is done, which is the urine checking for urine. That's the urinalysis, and then protein
Yeah.
is identified. Then it means you are going to be diagnosed as having what? Preeclampsia, right?
Okay.
Okay, I think we can go on.
Yeah, so it means when we go and we check our BPs for the pregnant women and husbands, do ask your wives when you went for the antenatal, what was your BP, so that you can be able to ascertain if there is an alarm and you do your immediate. When she talks about diastolic, she's talking about the BP machine, the BP figure, the down one. That is the diastolic. And that is what we term as the relaxation of the heart. When the heart is relaxing, that's the diastolic she mentioned for us. Okay, so please take us through the ties gradually so that our viewers can also note it down, especially the husbands. Let's write it down for our wives. Thank you.
Thank you very much for that addition. It's very important that partners also get involved, right? Partner involvement in pregnancy goes a long way to help improve the outcomes of pregnancy. So thank you very much for that addition. So the types of preeclampsia, we have the mild preeclampsia, right? And mild preeclampsia is characterized by high blood pressure and protein urine. And to categorize preeclampsia as being mild, the protein urine is usually up to 2 classes. So when you take the strips that we use for measuring or analyzing the urine, it comes in different color shades. And those color shades, when the strip is dipped into the urine, it is picked out and it is cross-checked against which color coding or which color shade that protein is actually signifying. So that is able to tell you whether it is 2+, right? 1+. We even have trace. With trace, you notice that in where we are, it's normally yellow, right? So if it is yellow, it could be negative. That's normally negative. And then when the yellow is a little dim, then we pick that as 1+. Then it goes on and on and on. So when you are able to identify that the protein urine is 2+, with a blood pressure of 140 and a diastolic of 90 to 110, then you classify that kind of preeclampsia as being mild. And the mother and the fetus, they are generally stable. So a mild preeclampsia is not something we are too, in as much as we are worried, it's not something you want to take a very quick action, right? It's something that you can actually manage gradually throughout the pregnancy, because the mother and the fetus, they are generally stable, and careful monitoring and management will help to improve the delivery outcomes, right? So that's about mild preeclampsia. Then we also have severe preeclampsia, and that is where we do not want our mothers to get to, right? So with the severe form of preeclampsia, it's a more serious form of the condition, with higher blood pressure levels, significant protein urine, and more pronounced signs of organ dysfunction, right? So the criteria that we normally use is when the diastolic is equal to or greater than 110. Then the
Okay.
protein urea is also greater than 3 pluses. So 3 pluses and above. Then we will classify that as what? A severe preeclampsia. And normally when the tests are done, we will talk about that maybe as we go along
Okay.
to see what actually can account for the organ dysfunction and all that. Okay, so that's about the severe one. So
Okay.
other symptoms can include severe headache. So people who have severe preeclampsia, normally they will come to the antenatal clinic with severe headache. So when you are in your house, a pregnant woman, and you are experiencing, maybe you've not been experiencing headaches, then suddenly you notice that you are having severe headache, it's actually a cause for you to go back to the hospital to be assessed whether your blood pressures are within the normal range and what could actually be causing that severe headache, right? Other symptoms could also be visual disturbances, whereby the person will be saying, normally the mothers will say they are feeling dizzy, or they are not seeing clearly, which we call the blurred vision, right? So
Okay.
visual disturbances can also be associated with severe preeclampsia. Then abdominal pain and nausea, right? They'll be complaining of abdominal pain, and that could also be associated with severe preeclampsia. Okay. Severe preeclampsia actually poses greater risks to both the mother and the fetus, and it requires more intensive monitoring and treatment. So, unlike the mild preeclampsia, sometimes we could even let the mothers go home, right? And we'll keep monitoring the blood pressures, or we encourage them to even buy the BP apparatus and be monitoring it in the house, right? So that if there is any increase, then we show them the ranges, then they are able to report back. But the severe preeclampsia, because it poses greater risk to both the mother and the fetus, it will be very important that we keep them in-house. That's, we hospitalize them so that intensive monitoring and then treatment could actually be done. So that's about the severe preeclampsia. Then we have eclampsia. And eclampsia, like I earlier on said, is one of the leading causes of maternal mortality. And we do not want our pregnant women to even end up having eclampsia, right? So eclampsia is a severe form, and it involves the occurrence of seizures. So the high blood pressure, it could be so bad to the extent that the woman will start having seizures, like the epilepsy. You see how epilepsy, sometimes they have the seizures, right?
Sure.
The whole
Yeah.
body, to the extent that they bite their tongue and all that. So that's how eclampsia, that's how it portrays itself, right? The woman starts having
Okay.
seizures, right? And then the blood pressure will be very high. And when you take blood sample to go and run tests to find out how their organs are doing, especially the liver, the kidney, you see that the ranges are deranged, right? They are very high, right? So that is associated with eclampsia. And eclampsia is actually a medical emergency and requires immediate treatment to prevent harm to both the mother and then the fetus. Once a mother reports to the hospital with eclampsia, we are actually doing our possible best to end that seizure and also to end the pregnancy. So regardless of whether the mother has the baby has matured or not, we'll have to save the mother, because it's always in midwifery, we always say that we want to save our mothers first, because traditionally we say if the mother is alive, maybe she's having other children at home, she'll be able to best take care of those children. Or if she doesn't have any, she can achieve another pregnancy again. Right. So with eclampsia, it's an emergency and it needs to be managed immediately to prevent harm. Okay. Eclampsia, strangely enough, could also occur even in the first few days of postpartum. So even after delivery, so even with all the hypertensive disorders, we make sure that we continue to monitor this woman even after delivery, because after delivery, the woman is still at risk of developing those disorders. So eclampsia can occur in the first few days in the postpartum. A small portion of women with eclampsia might have normal blood pressures or slightly elevated blood pressure. That's why it's very important that every pregnant, once you identify that you are pregnant, you have to report to the hospital so that the necessary examination, necessary tests could be carried out. Because sometimes just from the history taken, you'll be able to identify that now this woman is someone that needs to be monitored closely so that she may not develop any of these conditions during pregnancy. Or if they even develop, we'll best be able to manage them.
Okay, so it means that's one of the reasons why some category group of people after delivery you don't discharge them, but you let them
Yes,
stay for some days.
yes,
I hope that is the reason.
yes,
So
that's the reason.
to the husbands, it doesn't mean that you need to go and put pressure on the midwives. My child, my baby is out, so no problem. Discharge them. Let's be calm because they have access and know what is best. We don't want any eclampsia or risk of this condition to occur. Thank you for the explanation. You can continue.
Okay, then we also have another severe form, which is the HELP syndrome, right? And when a woman gets to the HELP syndrome, it's actually very life-threatening. And so most of the time, we try our best to manage the woman at that eclamptic stage so that they don't get into HELP syndrome. So it's actually rare. It's not every woman who goes through, who is diagnosed as having eclampsia may develop HELP syndrome. It's a rare condition, but it is very serious, and it can occur in women with preeclampsia. So the HELP syndrome is actually an acronym that stands for hemolysis, which is the breakdown of red blood cells. So with this kind of women, you notice that either they are vomiting, and the the product that is coming out is bloody, right?
Okay.
Or sometimes when they urinate, you see that the urine is color colored, right? And that means that they are actually there's blood coming out of what the urine they are producing, right? So hemolysis the H stands for hemolysis. Then we also have elevated liver enzymes. The E is standing for elevated liver enzyme. So for this category of women, when you do their liver function, assess whether the liver is functioning well or not, you notice that the enzymes are elevated, right? And you are not expecting, because the liver does so many things in our bodies. We are talking about detoxification, deamination. It also helps to regulate sugar in our bodies and all that. So we don't expect the liver so worse that the liver will be damaged and the enzymes will be elevated. And we also have a low platelet count, which is the LP, right? So with this syndrome, you notice that when you do the full blood count, normally when you go to the one to see your blood level and all that, that test, when it's done, you notice that the platelet is low. And platelet
Okay.
is because that is what helps to stop bleeding. So that this kind
Okay.
of woman, when she delivers, you are expecting that when she
Okay. So to our viewers and our listeners, as we are waiting for the network to work for us, we are waiting for the network to work for us. Yeah. So I think Sister Favor is back again. So okay.
okay. I think you lost me along the way.
Yes, please. And we
Oh, okay.
understand it. Okay, so you
Okay.
you 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 made a point that there's a need necessary for us to note the importance of our platelet, and when the platelet is low, it's indicating that clotting factor is being depressed. That explains why our pregnant women might vomit, and we can see blood stasis and there in it. Thank you. Okay, I don't know if you can continue.
Yes, please. We can continue. We can move away
Yeah.
from here. We can continue.
Okay. So we some are worried. Is it every woman that can get this condition? Or there are some things that can contribute to
So we
this
can move
particular,
on.
yeah. So I'm talking about those concerns. Some are raising concern. Some people are worried. Is it every woman who will get this condition? Or there are some
It
contributing
seems we
factors
are
that
all
can,
having a little challenge with the network. Is it okay now?
yeah, I can hear you. Hello. I hope Mr. Favor you can hear me. Okay. Okay. So please, because we are dealing with networking aspects, sorry for that, but we want to ask our guest for her to help us on this issue. That is it every woman who get pregnant can get this condition, or there are some contributing factors that can contribute to this condition. So that's what we are waiting for. So as we are still waiting for, we are waiting for our guest. What we need to note is that yes, once you are pregnant, it doesn't mean that all. The moment you identify that you are pregnant, you need to visit antenatal clinic so that they can take you through all these processes, and it will not reach where we are talking about. So Mr. Favor, we wanted to find out that is it every woman that gets pregnant develops this condition, or there are some contributing factors to that? But before that, Josephine Adebi said, good afternoon to you, watching you live from the Volta region. Kudos to the team. So that's another greetings and from Sister Josephine Adebi to Sister Favor. Okay, so what are some of the
Thank
contributing
you.
factors of this condition? Thank you.
Okay. So the exact cause of pregnancy-induced hypertension or hypertensive disorders is not fully understood, right? But there are several factors that may contribute to this. And one of them is placenta dysfunction. For some reason, some people, when they just get pregnant and the placenta just get formed, they develop this condition, right? So problems with placenta's blood supply can lead to elevated blood pressure. Also, genetics. A family history of hypertension or preeclampsia increases the risk. So maybe someone who is born to, or a mother who gets a pregnant woman who has a family history, maybe either her mother has hypertension, her father has hypertension, or anybody in their family has hypertension, could put her at risk of also developing that. Or a mother who has had hypertension in her previous pregnancy could also be at it. Increases the, it doesn't mean you may have it, but it actually increases the risk of developing hypertension in pregnancy. Then women who are getting pregnant for the first time, right? Some research has shown that women who are getting pregnant for the first time also have a higher risk of developing pregnancy-induced hypertension. Then women with multiple pregnancy, those who are carrying twins, triplets, quadruplets, all these things increases the risk of developing hypertension or pregnancy-induced hypertension. Then the age of the mother is also another factor, right? So women under 20 or over 40 years, they are more susceptible. And women who are also having diabetes, they are also at risk. All these conditions actually put women at risk of developing this condition.
Okay,
So what
so
are the
what?
signs?
Yeah, the signs and symptoms of it.
So PIH normally does not show any significant symptoms. So that's one of the major problems we have when it comes to the management, because it normally will not show you that you are having hypertension or not. There are no symptoms. I remember there was this medical director who did a research in one of our neighboring towns. He decided to distribute blood pressure, the machine, to
Okay.
saloons, the marketplaces, and all those things. And believe you me, the number of people who were actually having the high blood pressure when they came to access those services, it was just mind blowing. So, because it doesn't tell you any, it doesn't show you any sign, right?
Sure.
But with pregnant women, there are certain things that when they identify, they can actually report to the hospital to be checked to see whether they are having it or not. So one of the signs will be measuring high blood pressure that is elevated, right? So like I keep mentioning, 140 and 90 and above, right? It means that
Yeah.
you are having hypertension. Then proteinuria or protein in the urine due to kidney dysfunction could also be an indication. Then swelling. So some women will also have edema, especially in the hands and on the face. And in our locality here, sometimes when women have edema, you see people telling them, you are going to have a boy, you are going to have a girl, you are going to have twins. Please, edema is not an indication, or it is not able to determine the sex of the fetus you are carrying. It could actually be a symptom of some ongoing condition in your body. So you need to come for it to be checked. Then headaches, intense or persistent headaches, right? Then visual disturbances, like I earlier on mentioned, blurred vision, light sensitivity, or temporary loss of vision, right? Those things could actually give you some clue that you have to report for it to be checked, right? Okay.
Okay.
So this is just a pictorial representation of the symptoms, the things that you can see, and then it should prompt you that you need to go to the hospital to be checked. Yes. So okay, I think we can go on.
Yeah, so we thank you. So on this note, Sister Odro Doris Rabbi said, interesting topic. So I hope the women are listening and the men are writing. So they are not commenting here. They are writing for their wives. Thank you. So it means that we need to pay much attention to any sign that we will exhibit during
Yes.
pregnancy, because each of the sign gives us an indication. And if some places, as you were mentioning, in some places too, they will tell you when your legs and things get swollen, then it means you have stepped on something and there is a juju and this thing. But whether
Yeah.
juju or not, visit the antenatal clinic for them to assess you. So as you are doing your juju counter, then we are doing what can be best for you. Now we want to find out how can we, aside knowing these signs, I know the other thing to confirm this is some investigations. So, what are some of the investigations that we can conduct to confirm this condition? Thank you.
Okay, so most of the time when our mothers come, and then the first thing that needs to be done is the blood pressure recordings. That's why it's important you go to the antenatal, because on every visit the blood pressure is checked, and that's the first thing that is going to tell you whether this woman is developing a hypertensive disorder in pregnancy or not, right? So the first investigation that is done is the blood pressure recording. Then the follow-up investigations that are normally done is the full blood counts. And you see that big word over there, thrombocytopenia, right? That is going to indicate whether your platelet counts are okay or not, right? Then we also have urinalysis. So, like I earlier on said, every pregnant woman who goes to the antenatal clinic, they have their blood pressure recorded, and also we test the urine. We do not categorize, we do not, we do it for every pregnant woman. That's the urinalysis. So, your urine is going to be checked or tested for protein and also glucose, right? So, that's the urinalysis. Then we also have liver function test. That's also a follow-up test. So once you're able to uh, find out that the blood pressure is high, then you also do a follow-up of the full blood count, urine, protein, and then glucose. You do the liver function test to see whether the ongoing high blood pressure is damaging the liver or not. And normally when you do the liver function test, it's going to show you the ranged liver enzymes, right? Then we also
Okay.
have blood urea and then electrolytes. That is done using the kidney, doing the kidney function test. So that is also going to indicate the range kidney function, right? Because you are not expecting urea to come out of what? It's supposed to be excreted. You are not
Sure.
expecting it to remain in the blood, right? So
Sure.
once you do the blood test and you notice that blood urea is present in the blood, then it means that the kidney is not able to eliminate or take out that urea from your blood, right? Then it means there is some damage going on. Then we also have elevated uric acid. Then we do fibrin degradation products, and all these things are going to be elevated. So those are the basic tests that are normally done for our pregnant women with that condition.
So
Okay.
I think we will advise our viewers and our listeners here. You know, at times when they visit the antenatal clinics, they realize that,
Okay.
oh, most of the things should be free. But forgetting that if we detect that there is elevated level of the uric acid and things, and to do additional one, which is kidney, you realize that the price, they begin to
Yes.
complain. They begin to complain. So, viewers and our listeners, the facilities you will be visiting is not their happiness for you to be doing some of these labs to take just your money, as most people do say, but is to ascertain the exact and confirm the exact cause so that we will not get into the organ damage in terms of this pregnancy hypertensive disorders we are talking about. Thank you for this investigation. So, how then can we manage this?
Okay. So the management, there are different modalities that are used for managing hypertensive disorders in pregnancy. It will
Okay.
mainly be based on how severe the condition is, right? Whether we could manage out on outpatient basis, or you have to be what, be hospitalized, or we need to even end that pregnancy, right, to be able to save you, the mother, right? So close monitoring is essential for blood pressure, urine protein levels, and assessing the overall health. So most of the time when women are diagnosed as having hypertensive disorders, we continue to monitor the blood pressure, right? So that if we identify that maybe you came with just gestational hypertension, but suddenly it is uh, moving to maybe preeclampsia, then it means that maybe our management is not adequate. So we need to step up, right? So we have to continuously monitor the blood pressure, urine protein levels, and also assess the overall health. How is she doing? Some people may be able to even cope with the just a little elevation in blood pressure, and they will be doing fine. Baby will be fine, mother will be fine. But some people may not be able to, right? So we assess the overall health, and then we know how best to go about it. Then also, depending on the severity of the condition, rest is recommended. So most of the time, mothers who are having hypertension in pregnancy and all those other disorders, we encourage them to rest and reduce physical activity. Our mothers don't like to rest, especially when they are in the home and then the place is just a little scattered. They want to work from morning to evening just to ensure that the place is looking all cleaned up. But in this situation, you have to rest because of what the benefits it's going to bring to you, right? Also, severe preeclampsia or cases with rapidly worsening symptoms may require hospitalization for close monitoring. So someone who has a very high blood pressure, and we know that if we do not hospitalize you and manage, because sometimes we do that so that the woman can, even in the hospital, the rest may be enough. And that's one of the challenges we have with this management. Some mothers will be complaining that, oh, my husband is in the house and he will be hungry. I have to go home and then feed my husband, or I have to feed my children. So sometimes we ask them, if today you do not allow yourself to be managed properly and something, God forbid, but something should happen to you, how are they going to survive without you? Right? We need you alive to take care of those people in the house. So we have to go back and forth. Sometimes we have to go to the extent of even calling the chiefs of the town and all to try to convince, or our religious leaders have to sometimes come in to convince them to stay on admission so that we can monitor them closely, manage them. And if we are monitoring and we identify that no, the case is worsening, then we need to ensure that either we are ending the pregnancy or some other alternatives are being done. Please, we can go on. Also, medication wise, we normally give, let me see, prescribe. We give medications to do what? Reduce the high blood pressure, right? And in cases of eclampsia also, medications are given. We have medications that we give to prevent the seizures or to reduce it, right? So some of the antihypertensive drugs that are given, a disclaimer, not mentioning it so that you go over the counter to buy them when your blood pressure is high. All these medications are supposed to be given under supervision and also the right doses, right? So normally in the hospitals, we use labetalol. So if your partner is in the house and then is having labetalol, then it means maybe the blood pressure is a little elevated. We also use methyl dopa and nifedipine, right? And also hydralazine. The hydralazine, we have the tablet form and we have the ones we give parenterally, right? They are normally used to control the blood pressure and to reduce the risk of what? Complication. Okay. So that's about the management. Then also, when the preeclampsia is severe, we give magnesium sulfate. And the magnesium sulfate is often administered to prevent or treat seizures in severe preeclampsia or eclampsia. So with magnesium sulfate, it depends on every country and then their protocol, or every hospital and then the protocol they normally use, right? So I've just briefly explained how it is given. It normally comes in the 50% and also 20%, right? So the 4 grams of 20% is normally given intravenously, and the 50% is normally given intramuscularly through the buttocks, right? And it can be very uncomfortable. It gives that burning sensation and all that. That's why we are saying we don't want you to get there. But once it's given, it goes a long way to help to prevent seizures and also prevent the eclampsia from happening, or prevent complications. Okay, so when magnesium sulfate is being given, there are certain things we also look out for, right? We keep on monitoring the respiratory rate, the urine output, patellar reflex, pulmonary edema, and coagulopathy. We do all these assessments as we are giving the magnesium sulfate, because it has some complications of reducing the respiratory rate, right? And sometimes you notice that when it's being given, some people, their urine outputs will reduce drastically. So we monitor all these things before we continue to give. So at every dose that we need to give, it's normally given every 4 hourly. The 5 gram is given every 5 hourly, 4 hourly, and it's for 24 hours. So as we are giving, we are monitoring these things so that we are able to know that you are not getting into toxicity, or side effects are not actually occurring. So that's about the magnesium sulfate. We also give corticosteroids, such as betamethasone, dexamethasone, to help the lungs to develop. So in cases where we need to end the pregnancy for the sake of saving the mother's life, we also consider the baby, because some people may have struggled to actually achieve that one pregnancy. So we do our best to also save the baby. So we give corticosteroids that will help the lungs to also mature before the baby is delivered. Fetal monitoring is also very important, very crucial. We continue to monitor the fetus using the fetal heart rate monitoring. Then delivery planning is about timing, and the mode of delivery will depend on the severity of the condition. So in cases of severe preeclampsia, early delivery might be recommended to prevent further complications. Also, supportive care is very important. We expect our partners to be supportive emotionally, because this condition can be so depressing to the extent that women may go into postpartum depression after delivery, right? So we expect that the partners support their wives, right? And prevention of convulsion is also very important. I think that one, I've mentioned it earlier on. In all this, we know that for hypertension, even in a normal person, dietary management can never be taken out of it, right? Dietary management can never be separated, because these are conditions that can be managed using diet, right? So sodium intake, you have to limit. Women who have high blood pressure, they have to limit their sodium or their salt intake, right? So processed food, most of our processed food are being preserved with sodium. So we counsel mothers to prepare their meals from home, all right, so that they'll be able to control the amount of sodium they put inside, which is the salt. Then also a balanced diet is very important. So diet that are rich in whole grain, lean proteins, fruits, vegetables, and low fat dairy. Then hydration is also very important. In as much as it's important, we also know that there is a limit to which fluid can be taken in. Then foods that have omega-3, we know that omega-3 has been shown to have some benefits for the heart, right? So it's very important that they incorporate it in their diet, like the fatty fish, flaxseed, walnuts, and all these will help to what? Affect, they have a beneficial effect on what? The blood pressure. So we have something we call the DASH diet, dietary approach to solving hypertension, right? So you have your carbohydrates, you have your fruits, your vegetables, and then you also have your proteins. So this is how the plate is supposed to look like for a mother who is having hypertension in pregnancy. Okay. So but all these things, for when we want to use the dietary approach, I advise that it's very important that you talk to your dietitian to be able to help you to know which foods to take and which foods not to take. Because there are some people who have allergies, they're allergic to some of the foods we are mentioning and all that. So you have to work hand in hand with the dietitian to know how to go about dietary management. Okay. So we are moving on to the complication. Okay.
Sure. So before we go to the complications, you realize that whatever Richmond Media health issues are doing, it serves multi-task purpose. So we have some students watching us, we have some midwives watching us. That's why our guest did best and fantastic job by going to some of the drugs that can be used in this management. Therefore, we are not saying that go and buy them, and she mentioned it. We are not saying go and buy them, because even the drugs she mentioned, you visit your gynecologist or your midwife, and upon assessment, your different from what different woman will also be taking. Therefore, it's always important that you visit your midwife or your gynecologist, then they handle this case with you. Same like the nutrition aspect, so that we can be able to manage. Thank you for, we are enjoying this lesson, and the way you have taken your time, taking our viewers and our listeners through, we really appreciate that. We don't want to reach this stage, but if someone, just what we are saying is not adhering to the courses, the science, and neglect, what are some of the complications? Complications mean the worst state of this condition. Thank you.
Okay. So with the complications that could actually occur with these disorders, these hypertensive disorders, is intrauterine growth restriction. So you notice that a mother may be, let's say, 7 months or 28 weeks. But when you measure the abdomen is going to be like someone who is just 20 weeks pregnant or 5 months pregnant, right? It means that the blood supply or nutrition is not getting to the baby because of the dysfunction that is happening in the placenta, right? So it can cause the fetus not to grow very well in the uterus. Then we also have fetal hypoxia and intrauterine death. It can be so bad that oxygen supply to the baby will be restricted, and it can cause death once the baby is not getting enough oxygen. Then there could also be abruption of the placenta, where the placenta will separate once, even though the fetus is in utero. We are we are expecting that once a woman gets into labor, she delivers her baby before the placenta will follow, because that's what is giving oxygen and food to the baby. But because of this condition, the placenta can actually separate way before even labor gets to play. And when this happens, we can either lose the mother or even the baby if prompt action is not taken. Then we have the HELP syndrome, which I earlier on explained. We have the eclampsia, where they'll be having fits, they'll even be biting their tongue, and they have swollen tongue and all that. Then renal failure. So it can be so bad that the kidneys will just shut down, and then the person will go into renal failure. It can also cause cerebrovascular accidents where they will develop stroke, right? Just like the hypertension that occurs in the normal people. Then we also have cardiac failure, where the heart will fail, right? And then it has a lot of complications that comes with it. So in conclusion, we are saying that proper medical supervision and guidance they are very essential for the management of pregnancy-induced hypertension. It's very important that once you identify you are pregnant, you attend the antenatal clinic, and when you are diagnosed as having any hypertensive disorder in pregnancy, it is not a means to an end. It does not mean your life has ended. When you take the necessary precautions, making sure you adhere to all the medications that are given to you and all the other education that will be given to you, you'll be able to come out with good outcomes after delivery, and even you and your baby are also going to be in good health. So with that being said, I think that will bring us to the end of hypertensive disorders in pregnancy.
Okay, thank you very, very much for this in-depth knowledge. And someone is asking that, as you mentioned about fetal distress, then we hope that you can prepare, and next time you take us through the management, how we can prevent or preventive measures of fetal distress. And that's a request from one viewer. How do you
Oh,
respond to that?
I think we can look at that maybe some other time. It's
Yeah.
not a
Yeah.
problem at all.
Okay. So Sister Christiana Sapon said, thanks very much. I think we have all enjoyed this lesson. So upon Sister Favor is a senior midwifery officer, yes. And so when it comes to issues concerning pregnancy and all the nitty-gritties in pregnancy, in book experience and everything, I think she has been helpful. And as she was doing the delivery, I hope we all enjoy. So Richmond Media Health Issues, from UK, we are saying that God bless you for your time, your energy, and this selfless explanation, education you have given to the world through this channel. So God bless you. Sister Christiana Sapon said, well understood. This one, your teachers, your students are saying they've well understood. Said, well done, sister. So these
Thank
are the
you
things
so
they are
much.
saying.
Thank you
Yeah.
so much for having me, and I'm very happy that I've been able to share this little knowledge with our audience.
Sure. So, on this note, we are saying that the request has been granted. So, we will book with Sister Favor again, and she will come again with management or preventive measures of fetal distress. So, to our viewers, we thank you. Amidst your busy schedule, you also have time with your credits, your bundles, your eye, your strength, viewing us and listening to us around the globe. We say that God bless you all. So here is where we will end today's lesson. And God bless our facilitator. We can't thank her, and we can't say anything that we are saying that we appreciate the selfless education you have given to us. I hope the husbands are also writing things, as well as the pregnant women are also adhering to it. So thank you for the presentation, and until then, same time next week, Richmond Media Health Issues will come to your doorsteps with different topic. God bless us all, and bye-bye for now.
Say